Gastrointestinal and hepatic disorders in the pregnant patient. Shilpa Mehra, John F. Reynes. 40 Gastrointestinal and hepatic function in normal pregnancy. The GI tract undergoes dramatic modifications during pregnancy. Intra-abdominal organs must move to accommodate uterine growth, hormonal factors alter motility, and the immunologic adaptation to pregnancy affects response to disease. Heartburn, nausea, abdominal cramps, and altered bowel habits, the most common GI symptoms of pregnant women, are caused by normal physiologic changes in gut motility. These symptoms are usually transitory and easily treated with conservative measures. It may be a challenge, however, to distinguish between symptoms of altered motility and those that signal the onset or worsening of problems that require immediate medical attention. Esophageal function. The amplitude and duration of esophageal muscle contractions in pregnant and non-pregnant women are similar. 1 In the distal esophagus, the velocity of peristaltic waves has been found to decrease by approximately 1/3 during pregnancy, but remains within the normal range. 2 In contrast, resting lower esophageal sphincter tone progressively declines during gestation, most likely a consequence of inhibition of smooth muscle contraction by progesterone. 2-4 This effect, coupled with increased abdominal pressure during gestation, is responsible for the gastroesophageal reflux symptoms that occur in 70% of pregnant women. 5 GI function. The effects of pregnancy on gastric motility are unclear. Delayed gastric emptying has been demonstrated by some authors, especially during delivery. 6 Whereas no effect on gastric emptying has been found by others. 7 Pregnant women have normal gastric secretion. 8 Intestinal transit time is prolonged during gestation. Delayed small bowel transit is most pronounced during the third trimester and is associated with slowing of the migrating motor complex. 9, 10 Colonic transit time is prolonged in pregnant animals. Progesterone is thought to have a direct inhibitory effect on gut smooth muscle cells that slows motility. 11 A role for endogenous opioids has also been suggested. 12 Together, these changes often result in mild physiologic constipation. The absorptive capacity of the small intestine increases during pregnancy to meet the metabolic demands of the fetus. Increased absorption of calcium, amino acids, and vitamins has been demonstrated. 13-16 Animal experiments have revealed pregnancy-induced increases in small intestinal weight and villus height in conjunction with mucosal hypertrophy. 17-18 The activity of some brush border enzymes increases during lactation and then decreases after weaning. 19-20 Immune function and the intestinal microbiota during pregnancy. The maternal immune system must adapt to the presence of the fetus. Adaptive changes can influence the response to infection and modulate the course of underlying autoimmune disease. There is a shift from cellular to humoral responses, with downregulation of Th1 and upregulation of Th2 cytokines. Pregnancy modulates natural killer cell cytotoxicity and induces T-regulatory cells that affect the maternal immune response. 21-22 Unfortunately, we still do not understand the effects of pregnancy on the mechanisms responsible for autoimmune diseases such as autoimmune hepatitis and Crohn's disease well enough to allow us to predict clinical outcomes during pregnancy. The maternal intestinal flora changes during pregnancy, potentially altering the host microbial interaction in a beneficial fashion. 23 Bacteria from the mother colonize the neonate's gut, establishing the microbiota with potential long-lasting health consequences. 24 Although the establishment of the human GI microbiota previously was thought to begin at birth, the finding of bacterial products in meconium, placenta, and amniotic fluid suggests that seeding occurs in utero. 25-26 Gallbladder function. Pregnancy causes an alteration in bile composition, including cholesterol supersaturation, decreased chenodeoxycholic acid and increased cholic acid concentrations, and an increase in the size of the bile acid pool. 27 These changes are associated with greater residual gallbladder volumes in the fasting as well as fed states. Sex steroid hormones may inhibit gallbladder contraction in pregnant women, promoting precipitation of cholesterol crystals and stone formation. 28-29 Hepatic function during pregnancy. Maternal blood volume increases progressively until week 30 of gestation when it is 50% greater than normal and remains so until confinement. 30 This volume expansion, attributed to the effects of steroid hormones and elevated plasma levels of aldosterone and renin, is responsible for dilution of some blood constituents such as red blood cells, physiologic anemia. Thus, total serum protein concentrations diminish 20% by mid-pregnancy, largely as a result of a reduced serum albumin level. Maternal proteins passively diffuse across the placenta to the fetal circulation. 31 Similarly, fetal AFP moves across the placenta from the fetal to the maternal circulation, raising maternal serum levels. Active transport may be involved in the transplacental movement of some macromolecules. Despite increases in maternal blood volume, the levels of many serum proteins measured to assess hepatic injury are unchanged or even increased during gestation. Progesterone causes a proliferation of smooth endoplasmic reticulum, whereas estrogens promote formation of rough endoplasmic reticulum and associated protein synthesis. Pregnant women synthesize the products of the cytochrome P450 gene superfamily and other proteins at an accelerated rate, including coagulation factors, binding globulins, and ceruloplasmin. Maternal serum alkaline phosphatase levels are normally elevated during the third trimester of pregnancy, largely due to placental production. For this reason, measurement of alkaline phosphatase in pregnant women is only of clinical use early in gestation. Alterations in maternal concentrations of plasma proteins may persist for several months postpartum. Mild leukocytosis and increased erythrocyte sedimentation rates are also common in normal pregnancy. Drug safety in pregnant patients. Patients and physicians tend to avoid treatment with medications during pregnancy because they fear harming the fetus. 32-33 Withholding medical intervention, however, may adversely affect the mother's health and the pregnancy outcome. Having stated this, no medication or other therapeutic intervention can be considered definitely safe during pregnancy. Indeed, the placenta is not a reliable barrier to the passage of most drugs. The distribution of a drug within the fetal compartment cannot be accurately predicted, and data on long-term effects of in utero fetal drug exposure are practically impossible to collect. The necessity of any proposed drug therapy should be discussed with the patient, and known and unknown risks of treatments must be carefully evaluated. For this reason, the FDA in 2014 required a change in the content and format of prescription drug labels required by the physician labeling rule. 34 Letter categories A, B, C, D, X are no longer used. Instead, the FDA now requires labels to contain a narrative explanation of risk and supporting data. Endoscopy during pregnancy. It is estimated that 20,000 pregnant women undergo endoscopy each year. 35 Recommendations concerning endoscopy in this setting are largely based on expert opinion and case reports. 36 Although the safety of endoscopy during pregnancy has not been completely established, it is performed routinely if there is a clear indication. 37 Pregnant women have safely undergone EGD, colonoscopy, sigmoidoscopy, ERCP, and percutaneous gastroscopy. 38 Although a recent large Swedish cohort study found endoscopy during pregnancy to be associated with an increased risk of preterm birth or small for gestational age neonates, the authors concluded that the risks were small and likely due to intrafamilial factors or disease activity and not because of endoscopy alone. 39 In addition to general contraindications to endoscopic procedures, specific contraindications during pregnancy include imminent or threatened delivery, ruptured membranes, placental abruption, and pregnancy-induced hypertension. 40 Several precautions should be observed to avoid complications when performing endoscopy in a pregnant patient. 40 Given the extreme sensitivity of the fetus to maternal hypoxia, pregnant women should receive supplemental O2 with continuous saturation monitoring. When the fetus is capable of surviving outside the uterus, usually around 24 weeks of gestation, maternal monitoring for contractions before, during, and after invasive procedures is advisable to enable prompt delivery if fetal distress occurs. In the second and third trimesters, the supine position and external abdominal pressure should be avoided because resulting compression of the vena cava and aorta may cause hypotension and placental hypoperfusion. ERCP should be performed only with therapeutic intent and by expert endoscopists, and every effort should be made to avoid fetal radiation. See later. 38 Opioid, narcotic, analgesics cross the placenta, and benefits during endoscopy must be weighed against risks for the mother, see Chapter 42, and the fetus. Sedation with benzodiazepines should be avoided, especially during the first trimester, because diazepam has been reported to cause fetal malformations. 41,42 Extensive experience with propofol is lacking, and its high lipid solubility is a reason for concern. 43 Lactating patients are advised to avoid breastfeeding and to discard breast milk for 4 hours after a procedure requiring sedation. 40 Imaging and radiation exposure during pregnancy. The National Commission on Radiation Protection recommends limiting exposure to ionizing radiation during pregnancy to less than 5 cgy. 44,45 Well-referenced guidelines for imaging of pregnant women with ionizing radiation have been published by the American College of Radiology Guidelines and Standards Committee 46 and by the American College of Obstetricians and Gynecologists Committee on Obstetric Practice. 47 The potential for radiation damage to the fetus is determined by dose and gestational age at the time of exposure. Table 40.1. CT should be performed only when its potential benefits clearly outweigh its risks and should be done, if possible, after completion of organogenesis. 48 Helical CT may be associated with less fetal radiation exposure than conventional CT. MRI is often a superior alternative to CT. MRI without contrast has not been associated with adverse pregnancy outcomes, and magnetic fields are not considered harmful to living organisms. 49 There is a theoretical risk of thermal injury to the fetus from MRI in early pregnancy, and thus MRI is not recommended during the first 12 weeks of gestation. Contrast agents may cross the placenta, and their safety in pregnant women has not been formally assessed. Neonatal hypothyroidism has been associated with use of some iodinated agents. Paramagnetic contrast agents used during MRI, e.g., gadolinium, have not been studied in pregnant women. Chapter 40 Gastrointestinal and hepatic disorders in the pregnant patient. 595 40 Less than 0.04% of a dose of gadolinium-labeled contrast is excreted in breast milk during the first 24 hours after administration, and a negligible amount of this is absorbed from the infant GI tract. 50 Therefore, breastfeeding should not be interrupted after imaging with gadolinium. US is widely used and safe during pregnancy. GI disorders and pregnancy. Nausea, vomiting, and hyperemesis. Gravidarum, see Chapter 15. In their first trimester, 60% to 70% of pregnant women report having some nausea, and more than 40% report vomiting. 51,52 Onset of these symptoms is typically in the 4th to 6th week of gestation, with a peak occurrence in the 8th to 12th week and resolution by week 20. Although nausea and vomiting may vary from mild to severe, most affected individuals are still able to obtain adequate oral nutrition and hydration, in some cases by eating frequent small meals of dry starchy foods. Hp infection in pregnant women may contribute to the development of vomiting. 53 Severe persistent vomiting demanding medical intervention, or hyperemesis. Gravidarum, is less common, occurring in 2% or less of pregnancies. 54,55 Hyperemesis is accompanied by fluid, electrolyte, and acid-base imbalances, nutritional deficiency, and weight loss, and is defined by the presence of ketonuria and a 5% decrease from pre-pregnancy weight. It may be associated with pyrosis, hematemesis, and hypersalivation, tylism. 56 Although the prognosis of hyperemesis gravidarum is generally favorable, severe untreated disease may lead to significant maternal and fetal morbidity. Symptoms usually begin at weeks 4 to 5 and improve by weeks 14 to 16 of gestation. In up to 20% of affected patients, however, vomiting persists until delivery. 57 Hyperemesis frequently recurs in subsequent pregnancies. Reported risk factors for hyperemesis include a personal or family history of the disorder. 58 A female fetus or multiple gestation, gestational trophoblastic disease, fetal trisomy 21, hydrops fetalis, and maternal HP infection. 59 The etiology of hyperemesis gravidarum is likely multifactorial, including contributions by hormonal changes, GI dysmotility, HP infection, and psychosocial factors. A genetic predisposition is suggested by familial clusters of the disease. Pregnancy-related hormones, specifically HCG and estrogen, have been implicated as important causes of hyperemesis. 60 Symptoms worsen during periods of peak hCG concentrations, and conditions associated with higher serum hCG levels, such as multiple gestation, trophoblastic disease, and trisomy 21, are associated with an increased incidence of hyperemesis. 61 Elevated serum estrogen concentrations, as seen in obese patients, have also been associated with this disorder. 62 Estrogen and progesterone are thought to cause nausea and vomiting by altering gastric motility and slowing GI transit time. 63 Other hormones implicated in the pathogenesis of hyperemesis include thyroid hormones and gut-derived hormones, ghrelin and leptin. 64,65 Abnormal thyroid function test results are found in 2/3 of patients with hyperemesis. Gravidarum. 66 The alpha subunit of hCG has thyroid-stimulating hormone-like activity that suppresses endogenous thyroid-stimulating hormone release and causes a slight rise in free thyroxine, T4, levels. 67 Despite these findings, this transient gestational thyrotoxicosis is not associated with unfavorable pregnancy outcomes and does not usually require treatment. An increased risk of hyperemesis has been found in 2 meta-analyses of Hp infection during pregnancy. 68,69 Some authors have documented symptomatic improvement in pregnant patients with vomiting after Hp eradication. 70,71 Vomiting in patients with hyperemesis. Gravidarum is often triggered by olfactory and even auditory and visual stimuli. A pregnancy-unique quantification of nausea and emesis, PUQE score, can be used to evaluate the number of hours of nausea and the number of episodes of emesis and retching per day in affected women and is helpful in tailoring therapy. 72 Hospital admission for fluid and electrolyte replacement and, sometimes, nutritional support is indicated when affected individuals develop hypotension, tachycardia, ketosis, weight loss, or muscle wasting. Abnormal laboratory test results in such patients include hypokalemia, hyponatremia, and ketonuria. Hyperemesis is associated with slight increases in serum aminotransferase and bilirubin levels in 25% to 40% of cases. Hyperamylasemia, seen in 1/4 of affected patients, is caused by excessive salivary gland production stimulated by prolonged vomiting. 73 Severe hyperemesis. Gravidarum is associated with poor maternal and fetal outcomes. In a study of more than 150,000 singleton pregnancies, infants born to women with hyperemesis who had gained less than 7 kg of weight during pregnancy were more likely to have low birth weights, be premature and small for gestational age, and to have low APGAR scores. 54 These findings were confirmed by a recent meta-analysis. 74 Severe, albeit rare, maternal complications of hyperemesis include Mallory-Weiss tears with upper GI bleeding, Hsv syndrome, Wernicke encephalopathy with or without Korsakoff psychosis, central pontine myelinolysis, retinal hemorrhage, and spontaneous pneumomediastinum. 75 Patients with hyperemesis may have depression and post-traumatic stress disorder during pregnancy and postpartum. 76 Lastly, severe depression after elective termination of pregnancy has been reported. 77 Given the potential for morbidity and mortality in hyperemesis. Gravidarum, affected individuals should be treated aggressively. Obstetric management should be overseen, if possible, by physicians qualified in maternal-fetal medicine. The goals of therapy are maintenance of adequate maternal fluid intake and nutrition, as well as symptom control. Patients should be advised to eat multiple small meals as tolerated and to avoid an empty stomach, which may trigger nausea. Also, avoidance of offensive odors, separation of ingestion of solid and liquid foods, and consumption of a high-carbohydrate diet may be helpful. 78 Antiemetic and anti-reflux medications are first-line pharmacologic therapy for outpatients who have failed dietary modifications. Ginger, phenothiazines, chlorpromazine, prochlorperazine, the dopamine antagonist metoclopramide, and pyridoxine, vitamin B6, have proved beneficial in this setting. 79,80 Extensive data show lack of teratogenesis and good fetal safety for many of these drugs. 81-83 Treatment with ondansetron, a 5-hydroxytryptamine 3, 5-HT3, receptor antagonist, should be considered in patients who do not respond to the above measures. The safety of ondansetron therapy during pregnancy is supported by a recent controlled trial 84 case reports, and widespread clinical experience. Glucocorticoids may benefit individuals with severe symptoms. Failure of oral medical therapy can be managed in the home setting with 4 fluid replacement medications and multivitamins. It should be noted, however, that as many as 50% of pregnant patients treated through central venous catheters, including those peripherally inserted, have catheter-related complications, 85 most likely as a result of the relative hypercoagulable state and increased susceptibility to infections seen in Table 40.1. Fetal effects of radiation during gestation *, gestational age, days, effects of radiation 0 to 9, death 13 to 50, teratogenesis, growth restriction 51 to 280, growth restriction CNS. Abnormalities, possible cancer risk *, effects listed are related to dose of radiation also. 596 Part 4 Topics involving multiple organs. Pregnant women. Enteral feeding through a nasoenteric tube or surgically placed feeding tube is sometimes required to maintain maternal nutrition. 86 Gerd, see Chapter 46. At least as many women experience pyrosis as nausea during pregnancy. By the end of the 3rd trimester, 50% to 80% of pregnant patients have had new, or an exacerbation of pre-existing, heartburn. 87,88 Pyrosis, however, is rarely accompanied by overt esophagitis or its complications. 89 Pregnant women with heartburn may also have regurgitation and, as already mentioned, nausea and vomiting, as well as atypical reflux symptoms, such as persistent cough and wheezing. Symptoms may develop at any time during pregnancy, with a peak incidence in the 3rd trimester. 90 may persist until delivery, and may be predictive of recurrent GERD later in life. 87 Risk factors for reflux include multiparity, older maternal age, and reflux complicating a prior pregnancy. 5, 87, 91 The contributions of pre-pregnancy BMI and excessive weight gain are controversial. 92 The pathogenesis of GERD in pregnant women is related to the effects of gestational hormones on esophageal motility, lower esophageal sphincter tone, and gastric emptying. Compression of the stomach and increased intra-abdominal pressure caused by the enlarging uterus also contribute to development of this disorder. EGD is rarely required for the assessment of pregnant women with symptoms of GERD. 93 There are no data assessing the use of 24-hour ambulatory pH monitoring in this setting, and use of a barium esophagogram is undesirable because it entails fetal radiation exposure. Thus, evaluation of suspected GERD in a pregnant woman depends on the clinical experience and judgment of the physician and requires due consideration of the patient's history and all potential, reasonable causes for the patient's present symptoms. Mild reflux symptoms can often be controlled by modifications of diet and lifestyle. Liquid antacids and sucralfate are prescribed as first-line pharmacologic therapy. 94 Magnesium-containing antacids should be avoided during the late 3rd trimester because they theoretically may impair labor. Ranitidine remains the treatment of choice for patients who have persistent heartburn despite liquid antacid therapy. 95 PPIs should be reserved for refractory cases. A large population study and 2 meta-analyses have found no significant risk of fetal malformations in babies exposed to PPIs during the 1st trimester of pregnancy. 96, 97 Omeprazole, however, has caused fetal toxicity in animals. An association between use of PPIs or H2RAS by pregnant women and development of childhood asthma in their offspring has been noted in a survey of Danish medical registries. 98 But the significance of this observation is unclear. The pro-motility agent metoclopramide has not been used extensively to treat GERD during gestation, although it is used during obstetric anesthesia and to treat hyperemesis gravidarum. PUD, see Chapter 53. Case studies and retrospective series suggest that the incidence of PUD is lower in pregnant women than in non-pregnant individuals. 99, 100 This impression, if it is valid, may be related to decreased use of NSAIDs by cautious patients or possibly to increased use of antacid medications to treat nausea or heartburn. It is conceivable, but equally unproved, that gestational steroids promote GI mucosal cytoprotection. PUD is likely underdiagnosed during pregnancy, given the reluctance of physicians to perform diagnostic tests on pregnant women. Gastric acid secretion and the natural history of Hp infection, as far as we know, are not altered by gestation. The dyspeptic symptoms that often accompany pregnancy, especially nausea, vomiting, and heartburn, may make diagnosis of PUD difficult. Because PUD is exceedingly common in the population as a whole, physicians who care for pregnant women should be vigilant for its occurrence. A trial of empirical acid suppression may be useful in women with suspected PUD and is thought to be safe. 101-104 In confusing cases, diagnostic EGD is indicated, see earlier. First-line therapies of PUD in pregnancy include ranitidine and sucralfate, although most PPIs are also effective. Patients with Hp infection may be given antibiotics during pregnancy or after delivery. IBD, see chapters 115 and 116. Physicians who treat patients with IBD are likely to encounter the disorder in pregnant women. 105 The majority of cases of IBD in women first present before age 30, the years of peak fertility. 106 Some authors report women to have an approximately 30% greater risk than men of developing UC or Crohn's disease. There is controversy regarding the effects of IBD on fertility. Pregnancy rates in IBD patients may be spuriously low because of self-image problems that result in sexual avoidance and voluntary childlessness. 107 Fear of IBD in offspring and fear of fetal malformation from maternal drug therapy are often cited as major causes of childlessness by affected women. 108 Female fertility itself, however, does not appear to be impaired by uncomplicated IBD. 109-110 A notable exception is fertility in UC patients treated with total colectomy and ilioanal J. pouch anastomosis. 111-112 A meta-analysis found a threefold increase in the risk of infertility in IBD patients who had undergone this procedure. 112 Infertility in these individuals is most likely caused by pelvic adhesions and fallopian tube scarring. Potential infertility should be discussed with patients of childbearing age who are considering this operation. Fertility in men with IBD is impaired by sulfasalazine treatment, which causes decreased sperm counts, which usually return to normal within 6 months of discontinuing the drug. 113 If the initial presentation of IBD is during pregnancy, the disease is often diagnosed during the first trimester. 114-115 Cases of this type are no more severe than those in non-pregnant individuals. Likewise, pregnancy does not appear to increase the severity of or morbidity due to pre-existing IBD. Evidence suggests that active disease around the time of conception increases the risk of disease relapse during pregnancy. UC patients relapse more often during pregnancy than Crohn's disease patients. 116 The goals of the treating physician are to minimize IBD symptoms and morbidity prior to conception. Most experts agree that during gestation, affected patients should continue optimized pre-pregnancy therapy to avoid possible flares resulting from medication withdrawal. Exacerbations of IBD that occur during pregnancy should be managed aggressively to avoid complications, including hemorrhage, perforation, sepsis, fetal demise, and premature labor. Treatment of fulminant colitis is the same as in non-pregnant individuals, namely high-dose glucocorticoids, 4 antibiotics, cyclosporin, and salvage biological therapies. The indications for bowel surgery likewise are the same as in non-pregnant IBD patients, although bowel surgery is associated with premature labor as well as maternal and fetal mortality. 117-118 A colostomy to achieve colonic decompression and fecal diversion may be safer than total colectomy. 119 Synchronous caesarean section and subtotal colectomy have been advocated for patients with fulminant colitis after 28 weeks of gestation. 120 IBD patients are at increased risk for poor pregnancy outcomes, even if they have mild or inactive disease. 121 Major complications include premature birth, low birth weight and small for gestational age infants, and increased caesarean section rates. 122 The risk of fetal malformations in this setting is unclear. 123 Pregnant women with UC may be at increased risk for thromboembolic events. 124 The majority of IBD patients require several medications to remain symptom-free. Some safety data are available regarding the teratogenicity of the most commonly used IBD drugs, but Chapter 40 Gastrointestinal and Hepatic Disorders in the Pregnant Patient 597-40 there are no long-term studies of their potential adverse effects on the offspring of affected patients. It is important to carefully review the possible risks and known benefits of therapy with patients before conception. Potentially teratogenic drugs should be discontinued before conception, if at all possible. Methotrexate and thalidomide are known teratogens in abortifacients and should be used with caution in patients of childbearing age. The optimum period of abstinence from these medications before conception is unknown, however, a minimum of 6 months is recommended. The 5-aminosalicylates are widely used during pregnancy to treat mild IBD. A prospective study of pregnant patients treated with mesalamine, as well as a large case series, did not show any increased risk of teratogenicity from this therapy. 125,126 azathioprine and its metabolite, 6-mercaptopurine, are among the most studied and widely used immunosuppressant medications in pregnant patients. Their metabolites are found in cord blood and excreted in small quantities in breast milk. Data concerning human use of these agents have failed to confirm the teratogenicity seen in animal studies. 127 Many studies of pregnant IBD patients treated with 6-mercaptopurine have not shown an increase in preterm delivery, spontaneous abortion, congenital abnormalities, or childhood neoplasia. 128-130 Based on these data and extensive experience with this drug and its metabolites in pregnant women, experts concur that their discontinuation before or during pregnancy is not advisable. Instead, careful monitoring of metabolite levels in the mother are recommended. 131 Glucocorticoids have been used for decades to treat pregnant patients with moderate to severe IBD, as well as other more common glucocorticoid-responsive diseases such as asthma. Early reports suggested an increased risk of congenital malformations in the infants of treated mothers. 126 Subsequent prospective studies and substantial experience with drugs in this class confirm that the risk of malformations secondary to their use is extremely low. Glucocorticoid treatment during pregnancy is, however, associated with other complications, including maternal glucose intolerance and hypertension, risks factor for preeclampsia, macrosomia, and fetal adrenal suppression. 132 Prednisolone is more efficiently metabolized by the placenta than other glucocorticoids and may pose less risk of adrenal suppression. 133 Adverse outcomes have not been reported after use of oral budesonide in a small number of pregnant patients. 134 Many pregnant organ transplant recipients have been treated with cyclosporin as immunosuppressive therapy, without reports of significant teratogenicity. TNF-alpha antagonists have been used extensively to treat IBD and other inflammatory diseases. Serum infliximab levels increase, whereas serum adalimumab levels are stable. During pregnancy. 135 These immunoglobulins reach the fetal compartment, especially during the third trimester. An exception may be certolizumab, which lacks the Fc fragment required for active transport. The drugs are concentrated in the fetus and are detectable in the infant's blood for months after birth. 114,136 Post-marketing registries of safety data and case series have not identified an increased incidence of fetal malformations or miscarriage in women treated during pregnancy with infliximab or adalimumab. 137 Recently published guidelines recommend that TNF-alpha antagonists be continued throughout pregnancy, unless otherwise indicated. 138 Some experts have expressed concerns about potential detrimental effects of fetal exposure to TNF-alpha antagonists on the development of the neonatal immune system. For this reason, babies exposed in utero to drugs in this class should not receive live vaccines during the first 6 months of life. However, other vaccines are recommended. 139 There has been no increase in the short or long-term incidence of infections in children who have been exposed in utero to TNF-alpha antagonists. 140 There is still limited data on the effects of treatment with anti-integrin and anti-IL-12/23 antibodies, vitalizumab or natalizumab and ustekinumab, respectively, during pregnancy. Although no problems were identified in one small study of pregnancy outcomes in women exposed to vitalizumab, pregnant women should not be treated with these medications until more safety data become available. 141 Vaginal delivery is not contraindicated in IBD patients, but cesarean section is recommended for patients with active perineal disease. Patients with ilioanal pouches are often advised to avoid vaginal delivery in order to avoid anal sphincter injury. Appendicitis. See Chapter 120. Suspected acute appendicitis is the most common non-obstetric indication for exploratory laparotomy in pregnant women. 142,143 Appendicitis complicates approximately 1 in 1,500 pregnancies and may develop at any time during the course of gestation. 143 Diagnosis may be difficult because the enlarging uterus displaces the cecum and appendix cephalad, altering the location of pain caused by appendiceal inflammation and resulting in increasingly delayed detection. As pregnancy progresses. 144 Late diagnosis of an inflamed appendix is responsible for complications that are associated with excess maternal and fetal morbidity and mortality. 145 During all 3 trimesters of pregnancy, RLQ pain is the most common presenting symptom of appendicitis. 146 In addition to pain, affected individuals frequently complain of nausea, but this symptom is often difficult to interpret during gestation. Graded compression US of the appendix is the diagnostic test of choice for pregnant patients suspected of having appendicitis. 146 Helical CT has also been reported to be helpful in this setting. 143 Pregnant patients with appendicitis during any trimester may be treated with laparoscopic appendectomy. 147 Although potential interference by the gravid uterus may be a relative contraindication to this procedure during the 3rd trimester. 148 Appropriate supportive care can prevent fetal loss. Associated with appendiceal perforation. 149 Gallbladder and pancreatic disorders and pregnancy. Gallstone disease. See Chapter 65. Pregnant women tend to form gallstones because of changes in gallbladder function and bile composition. See earlier. Gallstones are frequently noted during gestation when US examination is performed to evaluate the FET-US 150. The prevalence of gallstones in asymptomatic pregnant women is reported to be between 2.5% and 12%. Despite this high prevalence, the incidence of acute cholecystitis is not increased by pregnancy. When necessary, surgical intervention for gallstone-related disease does not increase the risk of preterm labor or of fetal or maternal mortality. 73,151 Endoscopic extraction of bile duct stones with minimal use of fluoroscopy and appropriate maternal shielding is acceptable when necessary to treat cholecystolithiasis during pregnancy. 152 Endoscopic intervention was found to be associated with fewer hospital admissions and a lower caesarean section rate than conservative treatment in one study. 153 Acute pancreatitis. See Chapter 58. Acute pancreatitis is uncommon during gestation, occurring once in every 1,066 to 3,300 pregnancies. 154,155 Most cases are caused by gallstones and present during the 3rd trimester or the puerperium. The mild hypertriglyceridemia normally seen in pregnant women may be more severe in persons with familial hyperlipidemia, predisposing them to develop pancreatitis. On this basis. 156 The clinical characteristics of acute pancreatitis during gestation are similar to those in non-pregnant women, although complications of pancreatitis do not develop in the majority of pregnant women with this disorder. 157 598 Part 4 Topics involving multiple organs. Hepatic disorders unique to pregnancy. Pregnant women may develop liver diseases that are etiologically related to gestation or its complications. 158 As a rule, these disorders become clinically evident during the 3rd trimester or just after delivery. They may be severe, even life-threatening, but affected individuals are expected to survive with prompt diagnosis and appropriate management. Liver diseases unique to pregnancy are also associated with increased fetal morbidity and mortality. Cholestasis of pregnancy. Cholestasis of pregnancy is a form of intrahepatic cholestasis associated with pruritus, elevated serum bile acid levels, and the finding of bland cholestasis on liver biopsy. 159,160 This disorder may have a variable course, making it difficult to diagnose. Nevertheless, it has serious implications for fetal well-being, and cases must be identified as promptly as possible. 161 Cholestasis of pregnancy usually presents in the 3rd trimester, but may be seen earlier in gestation, even in the 1st trimester. Its first and most characteristic symptom is pruritus, and, as a result, patients may be referred to a dermatologist for initial evaluation. As in other forms of cholestasis, the pruritus of cholestasis of pregnancy is most severe in the skin of the palms and soles and experienced most intensely at night. Only 10% to 25% of affected individuals later develop jaundice. Elevated serum bile acid levels, greater than 10 mol/L, confirm the presence of cholestasis. Some patients with the disorder also have bilirubinuria and even mild hyperbilirubinemia. 162 serum alkaline phosphatase concentrations are modestly increased, but GGTP levels are normal or only marginally elevated. 162 The latter pattern of test results is atypical of adult cholestasis but is seen in pediatric patients with progressive familial intrahepatic cholestasis, as in Byler syndrome. 163 Serum aminotransferase levels are elevated in affected women, sometimes to values of 1000 U/L or higher, making it difficult, on occasion, to distinguish cholestasis of pregnancy from viral hepatitis. An increased serum autotaxin level has been shown to be a sensitive and specific diagnostic test that can distinguish cholestasis of pregnancy from other pregnancy-related liver diseases. 164 Symptoms and laboratory test abnormalities of affected patients may wax and wane. Intense cholestasis is associated with steatorrhea that is usually subclinical but can cause fat-soluble vitamin deficiencies, most notably deficiency of vitamin K. Improvement of symptoms and laboratory test results begins with delivery of the infant, and usually, although not invariably, is prompt and complete. Rare patients experience prolonged cholestasis that may be indicative of underlying biliary tract disease, such as PBC or sclerosing cholangitis. 165,166 Women with ordinary cholestasis of pregnancy have no residual hepatic defect after resolution of the disorder, but they are at increased risk for development of gallstones, cholecystitis, and pancreatitis. 167 In addition, 60% to 70% of affected individuals develop cholestasis during subsequent pregnancies, although recurrent episodes may be less severe than the initial one, or with use of oral contraceptives. The risk of recurrence with subsequent pregnancies is increased by interval cholecystectomy. 168 Cholestasis of pregnancy has serious implications for fetal well-being. There are many reports of increased frequencies of fetal distress, unexplained stillbirth, and need for premature delivery of the babies of women with this disorder. 169 Fetal hypoxia and meconium staining have been reported at delivery in 19% of Swedish women with cholestasis of pregnancy. 170 These complications were shown to correlate with maternal bile acid levels higher than 40 mol/L. 171 Although the risk to the fetus may be reduced by close monitoring of affected mothers, it cannot be eliminated completely. 172-175 Planned early elective delivery as soon as the fetal lungs have matured has been recommended for this reason. As discussed in Chapter 64, a number of the molecular mechanisms of bile formation have been elucidated in recent years, resulting in a more sophisticated understanding of many cholestatic disorders. 176,177 Mutations of the MDR3, ABCB4 gene are likely responsible for approximately 15% of cases of cholestasis of pregnancy. 178-181 The MDR3 gene product is a phospholipid flip passe that translocates phosphatidylcholine from the inner to the outer leaflet of the canalicular hepatocyte membrane, where it is solubilized by bile acids to form mixed micelles. There is, however, no relationship of cholestasis of pregnancy to HLA type. 182 Environmental, hormonal, and other factors also likely contribute to the development of cholestasis in pregnant women. In Chile and Scandinavia, where cholestasis of pregnancy is common, the disorder occurs most often during colder months. The incidence of cholestasis of pregnancy in Chile has declined, possibly owing to a fall in mean plasma selenium levels. 183 An increased sensitivity to the cholestatic effects of exogenous estrogen has been demonstrated in family members, including male relatives, of patients who develop cholestasis while pregnant. 184 Therapeutic or experimental administration of estrogen compounds to susceptible women can precipitate the disorder. 185,186 Similarly, progesterone therapy during gestation is associated with development of cholestasis. 187,188 The finding that ursodeoxycholic acid alters the metabolism of progesterone may explain its therapeutic effect in this setting. 189,190 It is possible that some women with cholestasis of pregnancy have inherited an enhanced sensitivity to estrogen or a variation in the metabolism of progesterone that causes cholestasis in response to a variety of stimuli, including some medications and dietary factors. 191 The incidence of cholestasis of pregnancy is significantly higher in women with hepatitis C than in other pregnant women. 192 The differential diagnosis of cholestasis of pregnancy includes other cholestatic disorders such as PBC, PSC, benign recurrent intrahepatic cholestasis, cholestatic viral hepatitis, toxic liver injury, and bile duct obstruction. Liver biopsy specimens of affected individuals reveal bland changes typical of cholestasis due to a variety of etiologies, but biopsy is not usually necessary to make the diagnosis. It is important to remember that pregnancy may exacerbate a pre-existing subclinical cholestatic disorder. For example, a family of sisters with progressive liver disease who also developed recurrent severe cholestasis of pregnancy was described in 1997. 165 Management of cholestasis of pregnancy is primarily palliative. 193,194 Ursodeoxycholic acid is helpful in relieving symptoms. 190 may reduce fetal complication rates. 178 and is well tolerated by mother and fetus. 195,196 Studies of treated individuals have demonstrated a change in the bile acid content of maternal serum and amniotic fluid, as well as increased placental bile acid transport. 197-199 Most investigators have prescribed a conventional dose, 15 mg/kg/day, although one report suggests that a higher dose, 20 to 25 mg/kg/day, is more effective. 186 Treatment with bile acid binders such as cholestyramine 196 and guar gum may also relieve symptoms. 200 But it is important to keep in mind that therapy with these agents worsens steatorrhea and resultant fat-soluble vitamin deficiencies. 201 Administration of S-adenosyl methionine to patients with cholestasis of pregnancy has had mixed therapeutic results. 202-204 Its use in combination with ursodeoxycholic acid may increase its benefit. 205 A short course of a glucocorticoid, e.g., oral dexamethasone 12 mg/day for 7 days, has been reported to reduce itching and serum bile acid levels in persons with this disorder. 206 But was also associated with clinical deterioration in one case. 207 Sedatives, such as phenobarbital, may relieve itching in cholestasis patients but may adversely affect the fetus. Exposure to ultraviolet B light has been suggested as therapy in this setting. As in other cholestatic syndromes, no treatment is uniformly effective in women with cholestasis of pregnancy, with the usual exception of delivery. Chapter 40 Gastrointestinal and Hepatic Disorders in the Pregnant Patient. 599 Preeclampsia. 40 Preeclampsia is a multi-system disorder characterized by de novo hypertension associated with endothelial damage and maternal organ dysfunction, possibly including the liver, that may produce severe, even life-threatening, complications and affect pregnancy outcome. 208 The placenta is essential to the development of this disorder, and severe cases are associated with pathologic evidence of placental ischemia. 209 Preeclampsia complicates 3% to 10% of pregnancies, occurring in the second half of pregnancy or the puerperium and most commonly, but not exclusively, in primiparous women or women with multiple gestations. 210 Usual criteria for making the diagnosis include a sustained blood pressure of 140/90 mmHg or greater after the 20th week of pregnancy in a previously normotensive woman, accompanied by proteinuria, greater than or equal to 300 mg/24 hr, which is approximately equivalent to a urine protein concentration of 30 mg/dl, 1 plus dipstick. On random testing. 208 Many patients are also hyperreflexic and have edema. Liver disease is recognized as a common and potentially ominous complication of preeclampsia. The Hellp syndrome, first described by Weinstein in 1982,211 is the most usual form of pre-eclamptic liver disease and may underlie development of hepatic hematoma, rupture, and infarction. 212-214 Evidence suggests that there are different preeclampsia phenotypes and that HELLP syndrome may be a distinct genetic and clinical entity. 215-216 Although preeclampsia is common in patients with acute fatty liver of pregnancy, AFLP, and may play a role in the pathogenesis of this disorder, AFLP is not usually classified as a pre-eclamptic liver disease. 217 HELLP syndrome HELLP is seen in up to 12% of women with severe preeclampsia, occurring in 0.2% to 0.8% of all pregnancies. 218-220 In the past, clinicians have relied on two major HELLP diagnostic classification systems, the Tennessee classification and the Mississippi triple class classification, which further categorizes affected individuals on the basis of the nadir of the maternal platelet count, box 40.1. More recently, the diagnostic criteria for HELLP syndrome have been standardized by the American College of Obstetricians and Gynecologists Task Force in Hypertension in Pregnancy, box 40.2. 221 In addition to the diagnostic abnormalities of hemolysis, elevated serum aminotransferase levels, and thrombocytopenia in conjunction with hypertension and proteinuria, patients with typical HELLP syndrome frequently have complaints of chest, epigastric, and RUQ abdominal pain, table 40.2. These symptoms are often accompanied by nausea, vomiting, headache, and blurred vision in varying combinations. Some pregnant patients, however, may present with an asymptomatic fall in the platelet count during observation for preeclampsia, or initially have no hypertension or proteinuria. 222 Other women may complain of malaise, suggesting the diagnosis of a viral syndrome. 223 Most affected individuals seek treatment after week 27 of gestation, but up to 11% may do so earlier. It is important to note that a delayed presentation of HELLP syndrome after delivery, despite absence of signs of preeclampsia at delivery, occurs in up to 30% of cases. 218 The diagnosis of HELLP syndrome is based on an assessment of the clinical circumstances and features of the illness at the time of presentation because there is no single diagnostic test that is specific for the disorder. 220-224 Hemolysis in patients with HELLP is mild. Fragmented red blood cells, schistocytes, are seen on smears, and the serum LDH level is elevated. Serum aminotransferase levels are also elevated, sometimes minimally and other times to greater than 1000 U/L in association with laboratory signs of cholestasis. 218-225 Serum bilirubin levels can often be mildly elevated, compatible with the finding of hemolysis. Elevated serum levels of glutathione S-transferase alpha 226 box 401 The Tennessee and Mississippi triple class diagnostic classification systems of the HELLP syndrome. Tennessee classification 1. Microangiopathic hemolytic anemia with abnormal blood smear, low serum haptoglobin, and elevated serum LDH levels. 2. Serum LDH level greater than 600 IU/L or twice the laboratory upper limit of normal, and serum AST level 70 IU/L or twice the laboratory upper limit of normal, or serum bilirubin level greater than 1.2 mg/dl3. Platelet count 100,000/μL. Incomplete HELLP syndrome is defined as the presence of only one or two of these abnormalities and may be less severe. Mississippi triple class classification class I, platelet count nadir less than or equal to 50,000/mm3 class II, platelet count nadir 50,000/mm3 and less than or equal to 100,000/mm3 class III, platelet count nadir 100,000/mm3 and less than or equal to 150,000/mm3 box 402 Recommended criteria for diagnosis of HELLP syndrome, ACOG Task Force in Hypertension in Pregnancy, 1. Hemolysis in at least two of the following: A. Schistocytes and Burr cells on peripheral smear. B. Serum bilirubin greater than or equal to 1.2 mg/dl. C. Low serum haptoglobin. D. Severe anemia unrelated to blood loss. 2. Elevated liver enzyme levels, AAST or ALT greater than or equal to twice the upper limit of normal. BLDH greater than or equal to twice the upper limit of normal. 3. Platelets 100,000/mm3 Table 40.2 Clinical characteristics and maternal complications of patients with HELLP syndrome presenting symptom: % affected abdominal pain, RUQ, epigastric, 65 nausea or vomiting, 36 headache, 31 bleeding, 9 jaundice, 5 laboratory test level, normal value, median, range, serum AST, 40 U/L, 249, 70 to 633, serum bilirubin, 1 mg/dl, 1.5, 0.5 to 25, platelet count, greater than 125 times 103/mm3, 57, 7 to 99, maternal complications: % affected DIC 21, abruptio placentae 16. Acute kidney injury 8, hepatic subcapsular hematoma 1, death 1 from Sci-BH, Ramadan MK, USTAI, ETAL. Maternal morbidity and mortality in 442 pregnancies with hemolysis, elevated liver enzymes and low platelets, HELLP syndrome. AMJ Obstet Gynecol 1993, 169:106. 600 Part 4 Topics involving multiple organs: D-dimer 227, tissue polypeptide antigen 228 and fibronectin 229 have been described in persons with HELLP syndrome, and these tests may have some use in predicting the presence or severity of liver disease. Abdominal imaging, especially CT and MRI, may be useful in making the diagnosis of HELLP syndrome and detecting cases of intrahepatic hemorrhage and infarction, discussed later. Imaging should be performed in patients with complaints of severe abdominal pain, neck or shoulder pain, or a sudden drop in blood pressure. One report documented abnormal imaging findings in 45% of such patients. 212 Liver biopsy specimens in patients with HELLP syndrome demonstrate periportal hemorrhage, intrasinusoidal fibrin deposition, and irregular areas of liver cell necrosis with mild reactive hepatitis, findings characteristic of preeclampsia, Fig. 40.1. If hepatic steatosis is present, it is modest and does not have the appearance of the extensive pericentral microvesicular fat accumulation that occurs in patients with AFLP, discussed later. There is little if any correlation between the severity of liver biopsy lesions and laboratory test abnormalities in patients with HELLP syndrome. Thus, mild thrombocytopenia and mild increases in serum aminotransferase levels do not necessarily connote insignificant liver to 0 MAGE. 230 Liver biopsy, however, is rarely necessary to make a diagnosis in these patients, and may possibly precipitate development of intraparenchymal hepatic hematoma or contained hepatic rupture. Although most pregnant women with low platelet counts and preeclampsia have HELLP syndrome, the differential diagnosis includes other causes of thrombocytopenia, including immune thrombocytopenic purpura, thrombotic thrombocytopenic purpura 231 and the antiphospholipid antibody syndrome, which itself may be associated with early onset of HELLP. 232,233 Elevated serum aminotransferase levels in patients with preeclampsia are most frequently misdiagnosed as being caused by viral hepatitis. 234. A diagnosis of AFLP should also be considered in patients with clinical findings of HELLP syndrome, but AFLP is usually associated with signs of more significant liver disease and possibly liver failure, albeit with lower serum aminotransferase levels, and is not necessarily associated with thrombocytopenia. Preeclampsia and HELLP syndrome are now thought to be consequences of abnormal placental formation in which failures of trophoblast invasion of the uterine lining and dilation of the spiral arteries result in the physiologic inability to increase uteroplacental perfusion appropriately as gestation progresses, with the secondary release of placental products that initiate clinical disease. 235,236 Female relatives, including the mothers of patients with preeclampsia, often have a history of the disorder, and evidence exists in some populations for its inheritance as either an autosomal recessive trait or an autosomal dominant trait with variable penetrance. 215, 237, 238. A number of maternal genetic variants have been associated with an increased risk of developing HELLP syndrome. 239-242. Early onset of HELLP or preeclampsia may be predicted by detection of specific serum factors, many of which have effects on angiogenesis. 243-247. Furthermore, women with a hypercoagulable condition, e.g., with factor V Leiden or anticardiolipin antibodies, are at risk for developing early and severe preeclampsia. 248-249. There is convincing evidence that development of this disorder is mediated by excessive release of soluble FMS like tyrosine kinase 1, SFLT1, into the circulation. SFLT1 is a potent antagonist of vascular endothelial growth factor, placental growth factor, and soluble endoglin, SENG, an inhibitor of capillary formation. 250-251. Pregnant rats that overexpress both SFLT1 and SENG develop proteinuria, severe hypertension, laboratory findings of HELLP syndrome, and intrauterine growth restriction. 252. Women with preeclampsia similarly produce excessive amounts of SFLT1 and SENG. 251. The clinical abnormalities that characterize HELLP syndrome usually resolve rapidly after childbirth. 253-254. Rarely, HELLP syndrome becomes gradually worse prior to delivery, with subsequent development of postpartum liver failure, sepsis, consumptive coagulopathy, and rarely, even death. 255. In the absence of appropriate supportive therapy and expedited delivery, affected patients may progress to renal failure, hepatic hematoma, and hepatic rupture. Neither serum aminotransferase levels nor platelet counts are predictive of outcome in women with HELLP syndrome. 256. The disorder can recur during subsequent pregnancies but usually does not. 257-258. Management of HELLP syndrome is primarily supportive. 254. Patients should be treated in an intensive care setting prior to delivery, preferably by an obstetrician qualified in the practice of maternal-fetal medicine. Some affected patients may have a decline in serum aminotransferase levels and a rise in platelet counts with supportive care. 259. Under such circumstances, a delay in delivery may be appropriate in cases of fetal immaturity, but the fetus usually fails to grow in the setting of preeclampsia. Patients with severe preeclampsia and HELLP syndrome may require antepartum platelet transfusions and hemodialysis. Plasmapheresis after delivery has been advocated for some patients to prevent postpartum thrombotic microangiopathy. 260-261. Many affected women receive glucocorticoids before delivery, not as disease treatment but to promote fetal lung maturity. However, glucocorticoid therapy has also been used as therapy in this setting. 262. Glucocorticoid therapy of HELLP syndrome may improve platelet counts and serum ALT levels and reduce hospital and ICU stays, but has not been associated with a significant improvement in maternal morbidity and mortality. 263. Orthotopic liver transplantation may be appropriate treatment for some HELLP syndrome patients. 264-266. But early diagnosis and prompt delivery almost always make this and other extreme therapeutic measures unnecessary in these individuals. Full recovery without sequelae is anticipated for the vast majority of affected patients. Those supportive measures just discussed are also employed in the nearly one-third of patients who develop HELLP syndrome postpartum, usually within the first 2 weeks after delivery. Hepatic rupture, hematoma, and infarct. Spontaneous rupture of the liver may complicate preeclampsia and HELLP syndrome, usually in the third trimester of pregnancy close to term or in the early postpartum period. Patients with this potentially fatal disorder present with abdominal distension and pain, with cardiovascular collapse. 267-268. In contrast to other patients with preeclampsia, women with spontaneous Fig 40.1 histopathology of HELLP syndrome. The portal triad on the left of the figure, the horizontal arrow points to an interlobular bile duct in the portal triad, is surrounded by pockets of hemorrhage, vertical arrows, and by an area of fibrin deposition, to the left of the portal triad. Chapter 40 Gastrointestinal and Hepatic Disorders in the Pregnant Patient 640 Hepatic Rupture tend to be older and to have had multiple previous pregnancies. Diagnosis is made by signs of liver rupture on US, CT, or MRI in conjunction with aspiration of blood on paracentesis. 212,269 Imaging studies often show that affected patients have a partially contained subcapsular hematoma, Fig 40.2. 270 In this situation, hepatic artery embolization may be effective in controlling bleeding and limiting morbidity and mortality. 271 Management must be aggressive, with rapid delivery of the fetus by the obstetrician and, if embolization is inadequate, to control bleeding, repair of the liver by an experienced liver surgeon. 272 Postoperatively, patients have a protracted course that may include DIC and hepatic failure. Patients with hepatic rupture have undergone orthotopic liver transplantation after emergent hepatectomy and interval portosystemic shunt as a temporizing measure while a donor graft is sought. 265, 266, 273, 274 Survivors of hepatic rupture may have uneventful subsequent pregnancies. 275 But recurrence of hematoma and rupture have also been reported. 276 Some pregnant women with preeclampsia, Hellp syndrome, and abdominal pain have contained subcapsular hematoma. 277 In this circumstance, patients can be observed with serial CT and managed without surgery. 212, 276 Angiographic embolization of hepatic artery branches supplying blood to the affected portion of the liver may be helpful. 271 Hepatic hematoma and rupture complicating preeclampsia presumably result from extravasation of blood from one or several microscopic areas of periportal hemorrhage under Glisson capsule. Periportal hemorrhage is a typical pathologic finding in the livers of patients with preeclampsia and Hellp syndrome. 278 The capsule is believed to be stretched and torn away from the surface of the liver by the enlarging hematoma. Ultimately, the capsule may rupture, allowing the liver surface to bleed freely into the peritoneal cavity. Hepatic infarcts may also complicate preeclampsia. Affected individuals present with fever, leukocytosis, anemia, and marked elevation of serum aminotransferase levels 212, 214, 279 and in the most severe cases develop multi-organ failure, including liver failure. Cross-sectional imaging demonstrates confluent hepatic infarcts. Needle aspiration of these areas yields blood and necrotic tissue. Immediately adjacent liver parenchyma contains periportal hemorrhage and fibrin deposition typical of preeclampsia and Hellp syndrome. Hepatic infarction is sometimes associated with the presence of a hypercoagulable condition, such as factor V Leiden or antiphospholipid antibody. 280 Acute fatty liver of pregnancy AFLP, a form of microvesicular fatty liver disease unique to human gestation, presents late in pregnancy, sometimes as fulminant hepatic failure with sudden onset of coagulopathy and encephalopathy in a woman without a prior history of liver disease. 281, 282 AFLP is diagnosed on the basis of typical clinical and pathologic manifestations in approximately 1 of 6,700 third trimester pregnancies. 283 But it also is recognized that subclinical cases exist. 217 A prospective study of more than 1 million pregnant women using the United Kingdom Obstetric Surveillance System and Standard Diagnostic Criteria, Swansea Criteria Box 40.3, 284 identified only 57 cases of AFLP. 285 The pathophysiologic mechanisms underlying development of this disorder are unknown, although at least some patients with AFLP have an inherited fatty acid oxidation defect that also affects the fetus. 286-290 AFLP presents late in pregnancy, usually between 34 and 37 weeks of gestation, although cases beginning as early as weeks 19 to 20 of gestation have been reported. Rarely, the onset of AFLP is after delivery. Initial symptoms usually include nausea and vomiting, often associated with abdominal pain. Pruritus may be an early complaint. Overlap with cholestasis of pregnancy has occurred but is rare. 291 Patients with AFLP are frequently confused and have pregnancy-related complications, such as premature labor, vaginal bleeding, and decreased fetal movement. The disorder is most common in primiparous women and in women with multiple gestations. 292 affected individuals have a much greater than expected number of male fetuses. 293 of note is the fact that preeclampsia, an accompanying diagnosis in 21% to 64% of cases. 283,294 is also associated with first pregnancies, twin pregnancies, and male fetuses. On laboratory evaluation, women with AFLP often have prolonged prothrombin times and decreased serum fibrinogen levels, as well as leukocytosis. Their serum aminotransferase levels are usually moderately elevated, 750 U/L, but, rarely, may be Fig 40.2 subcapsular hepatic hematoma in a patient with preeclampsia. This coronal section of a T1 weighted MRI scan demonstrates the subcapsular clot or hemorrhage, horizontal arrows, adjacent to the liver, vertical arrow. From Barton Jr., Sci-BM Hepatic Imaging in Hellp Syndrome. AMJ Obstet Gynecol 1996, 174:1820-5. Box 403 Diagnostic Criteria for Acute Fatty Liver of Pregnancy, Swansea Criteria, greater than or equal to 6 of the following, in absence of another explanation: abdominal pain, ascites or bright liver on hepatic US coagulopathy, PT greater than 14 SEC or APTT greater than 34 SEC, elevated serum ammonia levels, 47 mol/L, elevated serum AST or ALT levels, 42 IU/L, elevated serum bilirubin levels, 14 mol/L or 0.8 mg/dl, elevated serum urate levels, 340 mol/L or 5.7 mg/dl, encephalopathy, hypoglycemia, 4 mol/L or 72 mg/dl. Leukocytosis, 11,000/mm3, microvesicular steatosis on liver biopsy, polydipsia/polyuria, renal impairment, creatinine 150 mol/L or 1.7 mg/dl, vomiting, APPT, activated partial thromboplastin time, PT, prothrombin time. Adapted from CHNGCL, Morgan M., Hainsworth I., ETAL Prospective Study of Liver Dysfunction in Pregnancy in Southwest Wales. Gut 2002, 51:87680, and Knight M., Nelson Pierce C., Kuringchuk J.J., ETL. A Prospective Nation-AL Study of Acute Fatty Liver of Pregnancy in the UK. Gut 2008, 57:951-6. 602 Part 4 Topics involving multiple organs very high or even normal. Jaundice is common but not invariable. Renal dysfunction with elevations of serum creatinine, blood urea nitrogen, and uric acid levels is often present. The course of AFLP is quite variable. Hypoglycemia and hyperammonemia occur and should be suspected when at-risk patients exhibit signs of altered central nervous system function. Other complications of liver failure, including ascites, pleural effusion, acute pancreatitis, respiratory failure, renal failure, and infection, may develop in patients with AFLP. Vaginal bleeding or post-caesarean section bleeding is also common in these individuals. Transient diabetes insipidus is sometimes seen. 295 More rarely, affected patients have myocardial infarction. 296 or pulmonary fat emboli. 297 Diagnosis of AFLP is almost always based on the appearance of typical clinical features of the disorder, including laboratory test results, during the later stages of pregnancy. Hepatic imaging may confirm the presence of hepatic steatosis in patients with suspected AFLP. 298 and plays a crucial role in identifying hepatic hematoma, rupture, and infarction. Liver biopsy is usually unnecessary to make the diagnosis, but histologic results may be pathognomonic and, therefore, useful if the obstetrician has reservations about delivery. Transvascular sampling of liver tissue, however, may be necessitated by coagulopathy. The histologic hallmark of AFLP is small droplet fatty infiltration of the liver that is most prominent in hepatocytes surrounding central veins, zone 3, and sparse hepatocytes surrounding portal areas, Fig 40.3. Steatosis of this type has a relatively homogeneous appearance on light microscopy and may be difficult to discern on examination of ordinary H&E stained specimens. To confirm the diagnosis, special techniques must be used. Frozen tissue may be stained for fat with oil red O, or electron microscopy can be used to examine a glutaraldehyde fixed specimen. Plans must be made prior to the biopsy for appropriate handling of the liver tissue. Other histologic findings in affected patients can be misleading, including lobular disarray suggestive of viral hepatitis and biliary ductular proliferation, and inflammation suggestive of cholangitis. 217,299 patients with AFLP do not have the periportal hemorrhage and sinusoidal fibrin deposition seen in the livers of individuals with preeclampsia and Hellp syndrome. The differential diagnosis in suspected cases of AFLP includes those causes of acute hepatic failure not associated with pregnancy, as discussed later, especially viral hepatitis and toxic liver injury. Uncommon types of viral hepatitis, such as hepatitis E and herpes simplex hepatitis, may be more severe in pregnant than in non-pregnant individuals. 300,301 These viral agents can be identified by appropriate serologic tests. A more difficult problem is distinguishing AFLP from other liver diseases that complicate pregnancy, particularly the preeclamptic liver diseases, namely Hellp syndrome and hemorrhagic or ischemic liver injury. For example, patients with AFLP may develop preeclampsia and DIC with attendant thrombocytopenia, thereby meeting the diagnostic criteria for Hellp syndrome, see box 40.1. Fortunately, it is not usually necessary to distinguish among these various diagnoses because AFLP, Hellp syndrome, and preeclampsia are treated by expedited delivery of the infant. It is, however, of crucial importance to recognize hepatic hematoma and rupture rapidly, see earlier discussion. The pathogenesis of AFLP has not been elucidated. Initially, AFLP was thought to be caused by exposure to a toxin. For example, microvesicular steatosis of the liver can be caused by treatment with sodium valproate or 4-tetracycline. Despite an intensive search, however, no toxin that might be responsible for development of AFLP has been identified. Because of the coincidental occurrence of preeclampsia and AFLP in many patients, the disorder has been considered by some experts to be a severe form of preeclamptic liver disease. 217,302,303 Placental oxidative stress, thought to be responsible for development of preeclampsia, is accompanied by release of toxic mediators that may play a role in the pathogenesis of AFLP. 304 Arguing against this conclusion are the absence of the usual histologic features of preeclampsia in liver biopsy. Specimens from patients with AFLP and the absence of the usual clinical features of preeclampsia in many patients with AFLP. There is a well-established association between AFLP and inherited defects in beta oxidation of fatty acids. 287-289,305,306 This connection is empirically supported by similar clinical and histologic findings in patients with AFLP and those with Jamaican vomiting sickness, a liver disease caused by a toxin in unripe ackee fruit that disables intramitochondrial beta oxidation of fatty acids. Maternal liver disease, HELLP or AFLP, has been reported in 62% of the mothers of infants with defects of fatty acid oxidation. 287 AFLP may develop regardless of maternal genotype if the fetus is deficient in long-chain 3-hydroxyacyl coenzyme A dehydrogenase, LCHAD, and carries at least one allele for the G1528 CLCHAD mutation. 286,307 Another beta oxidation defect, carnitine palmitoyltransferase 1 deficiency, has also been associated with AFLP. 308 Prenatal genetic diagnosis based on chorionic villus sampling has proved to be feasible and accurate in pregnant members of affected families. 309,310 Not every investigator, however, has been able to confirm the association between AFLP and beta oxidation defects. 311 and other as yet unknown mechanisms may play a role in the pathogenesis of this disorder. Patients with AFLP should be managed in an intensive care setting, preferably by obstetricians qualified in the practice of maternal fetal medicine, in cooperation with other appropriate specialists. Early diagnosis and prompt delivery of the infant are imperative to minimize maternal and fetal morbidity and mortality. Affected individuals may be very ill postpartum until the physiologic defects responsible for their clinical abnormalities resolve and the livers recover. Supportive care may include infusion of blood products, mechanical ventilation, hemodialysis, and antibiotic therapy. Hepatic encephalopathy is treated as indicated by measures intended to evacuate feces and bacteria from the colon. Infusion of concentrated glucose solution may be required to treat or prevent hypoglycemia. Although many patients with AFLP have DIC and depressed antithrombin 3 levels, treatment with heparin or antithrombin 3 is not recommended. 312 Patients with diabetes insipidus may be managed with 1-deamino-8-darginine vasopressin. 295 Some individuals with liver failure secondary to AFLP require emergency orthotopic liver transplantation as a potentially life-saving measure. 266, 313, 314 Most affected women, however, recover completely with appropriate supportive care. Persistent or even increasing hyperbilirubinemia and multiple complications after delivery do not necessarily indicate the need for liver transplantation. Fig 40.3 Histopathology of acute fatty liver of pregnancy. The perivenular hepatocytes are pleomorphic and vacuolated, and there is lobular disarray. Large fat droplets are not seen. Chapter 40 Gastrointestinal and Hepatic Disorders in the Pregnant Patient. 603 Survival of patients with AFLP has been reported to be nearly 100% with prompt diagnosis, delivery of the infant, and intensive care. 283, 294, 315, 316 Infants of affected women have perinatal mortality rates of less than 7%. Surviving babies may have LCHAD deficiency and develop non-ketotic hypoglycemia and obtundation. Recurrence of AFLP has been documented, particularly in women with LCHAD deficiency. 317, 318 In all cases of AFLP, the mother, father, and child should be tested for the G1528C LCHAD mutation. 286 Other hepatic disorders and pregnancy. Viral hepatitis. Viral hepatitis is the most common form of liver disease worldwide, and frequently affects women of childbearing age, either as an acute infection or as a chronic disease. 319, 320 Hepatitis A, unless unusually severe, does not appear to alter the normal course of pregnancy, nor does pregnancy appear to influence the natural history of hepatitis A. Acute and chronic viral hepatitis of other types, however, may have implications for maternal and fetal well-being. HEV, see Chapter 82. HEV is an enterically transmitted RNA virus with 4 genotypes and 1 serotype. 301, 321 Genotypes 1 and 2 only infect humans and usually cause epidemic disease during the monsoon season in Central and South Asia and India. Genotypes 3 and 4 infect humans and numerous animal species, particularly swine and chickens and possibly cattle and sheep, as well as rats. These HEV genotypes are responsible for sporadic cases of hepatitis in farmers and may spread to others by consumption of undercooked meat. 322 The prevalence of HEV antibody has declined in blood samples collected in the U.S. from 2009 to 2010, as compared to those collected from 1998 to 1994. 320 Most recently the HEV antibody prevalence was 6% for individuals aged 6 years or above. 2 recombinant protein anti-HEV vaccines have been tested in clinical trials. 323 and one of them was approved for use in China by the State Food and Drug Administration in December 2011. Acute hepatitis E during the third trimester of pregnancy is a cause of fulminant hepatic failure and has a mortality rate of up to 20%. 301 Maternal HEV infection has also been associated with intrauterine fetal death. 324, 325 The risks of intrauterine death and abortion in any trimester are greater in pregnant women with hepatitis E than they are in their uninfected counterparts. Maternal fetal transmission of HEV resulting in symptomatic neonatal hepatitis has occurred. 326 And no known therapy prevents vertical transmission of this virus. Pregnant women should avoid traveling to endemic areas during monsoon season and outbreaks of the disease. HSV, see Chapter 83. Subclinical hepatitis associated with primary Hsv infection is common. In pregnant or immunosuppressed individuals, This virus may cause severe liver disease. 327 Infection during pregnancy, particularly the third trimester, can result in fulminant hepatic failure. Affected individuals are obtunded and usually anecteric with elevated serum aminotransferase levels and coagulopathy. They may have subtle oropharyngeal or genital herpetic lesions. Encephalopathy may result from herpes encephalitis. The diagnosis of Hsv infection can be confirmed by serologic testing and PCR assay for viral DNA. Liver biopsy specimens from affected patients usually demonstrate characteristic intracytoplasmic inclusion bodies and areas of focal hemorrhage. Treatment with oral acyclovir or valacyclovir is effective and appears to prevent viral transmission to the fetus. 328,329 HBV and HDV, see chapters 79 and 81. HBV infection in pregnant women is the most important factor perpetuating the worldwide epidemic of chronic hepatitis B. 333-32 Universal HBV screening in pregnant women is recommended. 333 Although HBV can be passed from infected mothers to their infants during gestation, at the time of delivery or after birth, most mother-to-infant transmission occurs during delivery, a time when the neonate's immune system is incapable of clearing the virus. Vertical transmission of HBV is responsible for most cases of chronic hepatitis B in endemic areas, especially Southeast Asia and Africa. 334 Maternal infectivity is proportional to viral load. 335 Mothers with a reactive serum test for hepatitis B E antigen have more circulating virus and higher rates of perinatal transmission. 336 Than mothers who have undetectable serum hepatitis B E antigen with a reactive serum test for hepatitis B E antibody. 337 Although the latter individuals can still be a source of neonatal infection. 338 Without treatment, 90% of infants born to hepatitis B E antigen positive mothers and 10% of infants born to hepatitis B E antigen negative mothers develop chronic HBV infection. Antiviral therapy beginning in the third trimester is recommended for pregnant women with inactive hepatitis B and serum HBV DNA levels greater than 200,000 IU/ml. 339 For pregnant women with active hepatitis B, management should be the same as that recommended for non-pregnant women. 340 Appropriate therapy during pregnancy significantly reduces the risk of mother-to-infant viral transmission. 341 If, however, the risk of transmission is low, antiviral therapy in addition to recommended. Prophylaxis of the infant offers no advantage. 342 Invasive procedures during pregnancy, such as amniocentesis, may pose a risk of HBV transmission from mother to child, especially when the maternal HBV DNA level is greater than or equal to 7 log copies/ml. 343 The infants of mothers with a reactive serum test for hepatitis B surface antigen should receive hepatitis B immunoglobulin and hepatitis B vaccine within 12 hours of delivery. 344 This treatment is highly effective, but despite appropriate passive-active immunoprophylaxis immediately after birth, 1% to 2% of treated infants will become chronically infected with HBV. 335,345 Breastfeeding by mothers with chronic hepatitis B poses no additional risk of viral transmission as long as the baby has received appropriate immunoprophylaxis. 346 Most women of childbearing age with chronic HBV infection are healthy virus carriers with a very low risk of developing disease complications. A flare of hepatitis, however, and in some cases even acute liver failure, may occur in previously asymptomatic individuals during the peripartum period. 347,348 In a recent study, approximately 25% of women with chronic hepatitis B had disease flares in the first few months after delivery. 349 Investigators have also found an increased incidence of spontaneous preterm birth in association with the presence of HBV DNA in umbilical cord blood. 350 For these reasons, pregnant and postpartum patients with hepatitis B should be monitored closely for up to 6 months after delivery. 351 The only hepatitis B treatments that have been studied in pregnant women are lamivudine, telbivudine, and tenofovir disoproxil fumarate, TDF. Of these, TDF is preferred because of its reliable efficacy and high barrier to emergence of viral resistance. TDF therapy during the third trimester in pregnant women with high serum levels of HBV DNA has been shown to significantly reduce the incidence of mother-to-child viral transmission. 341,352 There was no difference between treated and untreated women in the rates of prematurity, congenital malformations, and APGAR scores. Other studies have shown no difference in the incidence of adverse effects between TDF-exposed and unexposed infants. 353-355 Women with chronic hepatitis B are not treated with interferon during pregnancy. 356 Vaccination of non-immune pregnant women against HBV infection is safe and effective. 357 604 Part 4 Topics involving multiple organs. An accelerated vaccination schedule may be used in women at high risk for exposure to HBV. 358 when the indication for hepatitis B therapy is a third trimester serum HBV DNA level greater than 200,000 IU/ml, stopping treatment at, or within 4 weeks of, delivery is recommended. 359 Continued treatment for up to 12 weeks postpartum does not protect the mother from disease flares. 360 Hdv infection requires simultaneous acute or chronic hepatitis B virus infection. Pregnant patients with hepatitis B who are most likely to have HDV-CO infection include those with HIV and immigrants from areas of high HDV endemicity. These individuals should be tested for the presence of anti-HDV antibody, which indicates infection. 359 There is no evidence that pregnancy changes the natural course of hepatitis D. Prevention of vertical transmission of HDV is best accomplished by vaccination of the mother against infection with hepatitis B virus, or appropriate therapy of existing maternal hepatitis B prior to pregnancy in conjunction with vaccination and administration of hepatitis B immunoglobulin to the infant. A case report has documented prevention of vertical transmission of hepatitis B and D viruses by this management. 361 HCV, see Chapter 80, Recommendations for the Diagnosis and Management of Hepatitis C in Pregnant Women, and others, are continually updated by the Hepatitis C Guidance Panel of the OSLD and the Infectious Diseases Society of North America. 362 and are available on the internet at https://www.hpguidelines.org. Although there is currently no recommendation for universal HCV screening of pregnant women, HCV antibody testing is recommended for patients with a risk factor for viral exposure, such as a history of injection drug use. Every pregnant woman with HIV infection should be tested for simultaneous HCV-CO infection. Patients with reactive antibody tests should have confirmatory HCV nucleic acid testing. 363,364 Mother-to-infant transmission is the principal cause of hepatitis C in children. Between 1% and 2.5% of pregnant women in the U.S. have HCV infection. 365 The incidence of HCV vertical transmission is reported to be 5.8% in the children of HCV RNA positive, HIV negative women, and 10.8% in the children of HCV RNA positive, HIV positive women. 366,367 Greater serum levels of HCV RNA, as seen in HIV and HCV-CO infection, increase the risk of vertical transmission. Serum HCV RNA levels of 106 or greater copies/ml have been associated with vertical transmission in as many as 36% of cases. 368 Intrapartum exposure to infected maternal blood, prolonged rupture of membranes, and internal fetal monitoring have also been identified as possible risk factors for neonatal HCV infection. 369,370 The incidence of perinatal HCV infection does not seem to be related to whether the baby is delivered vaginally or by cesarean section. 368 Although HCV RNA can be detected in breast milk, 371 breastfeeding is not considered to be a risk factor for neonatal HCV infection. 372 Nor are there data that amniocentesis significantly increases the risk of fetal infection. Population-based and case control studies of the effects of maternal HCV infection on pregnancy outcomes have had inconsistent results. Chronic hepatitis C may be independently associated with development of gestational diabetes, preterm delivery, low birth weight, retarded fetal development, and cholestasis of pregnancy. 373-376 Cirrhosis, in particular, is associated with increased maternal and fetal morbidity. 377,378 There are no convincing data to suggest that pregnancy alters the natural history of hepatitis C infection, although pregnant women with hepatitis C have a higher incidence of cholestasis of pregnancy than uninfected controls. 192 When possible, women of reproductive age with hepatitis C should receive antiviral therapy before becoming pregnant. Direct-acting antiviral agents are not approved for use during pregnancy. No intra- or postpartum intervention has been shown to reduce the risk of vertical HCV transmission, including treatment of the infant with immunoglobulin. 379 Patients with hepatitis C are not treated with interferon/ribavirin during pregnancy. Ribavirin is a well-established teratogen. Previously infected individuals may have spontaneous HCV RNA clearance after delivery. 380 Chronic liver disease and portal hypertension, see chapters 92 and 94. Women with significant chronic liver disease and cirrhosis often have anovulatory menstrual cycles or are amenorrheic and therefore are unlikely to become pregnant. Only 37 cases of cirrhosis were identified using ICD-9 codes in more than 2 million pregnant women recorded in the California Birth Registry database between 2005 and 2009. 378 Portal hypertension, ascites, and compensatory dilation of submucosal esophageal veins connecting the portal circulation to the esophagus vein can occur in pregnant women with non-cirrhotic portal hypertension aggravated by physiologic increases in circulating blood volume. Even in the absence of pathologic causes of portal hypertension, these esophageal venous collaterals may become engorged during gestation owing to normal circulatory changes, including increased blood flow and compression of the inferior vena cava by the enlarging uterus, and may be seen on endoscopy. Enlarged veins of the latter type do not bleed spontaneously. Normal pregnancy-associated increases in maternal blood volume appear to aggravate the risk of variceal bleeding in individuals with underlying portal hypertension. 381,382 Esophageal variceal bleeding has been reported in 18% to 32% of pregnant women with cirrhosis and as many as 50% of those with known portal hypertension and 78% of those with pre-existing varices. In addition to variceal bleeding, women with chronic liver disease and portal hypertension who become pregnant may be at increased risk of death, hepatic decompensation, splenic artery rupture, and uterine hemorrhage, according to reports published between 1950 and 1980. 377,381 Cirrhosis appears to significantly increase the risk of preeclampsia, preterm delivery, low birth weight, and neonatal death. 378 Endoscopic band ligation is accepted as the preferred initial therapy of variceal bleeding in pregnant women, although no studies of its safety and efficacy have been done in this setting. Infusion of the somatostatin analog octreotide is also used on the basis of its effectiveness in non-pregnant patients. Vasopressin and octreotide infusions may theoretically cause uterine ischemia and induce premature labor. Despite the risks of associated radiation exposure, placement of a transjugular intrahepatic portosystemic shunt may be indicated when variceal bleeding cannot be controlled by any other means. 383-385 The OSLD has recommended that every individual with cirrhosis who does not have a liver stiffness less than 20 kPa, fibroscan, and a platelet count greater than 150,000/mm3 have endoscopic screening for esophageal varices. 386 Although there are no formal guidelines for prophylactic management of esophageal varices in pregnant women, beta-adrenergic receptor antagonists are tocolytic, but these drugs do not repress normal labor in chronically treated pregnant patients. Use of beta blockers as primary prophylaxis against variceal bleeding in pregnant women has not been formally evaluated. Some authors have suggested prophylactic band ligation, portosystemic shunt procedures, and caesarean section to decrease the risk of bleeding from varices during gestation. Ascites and hepatic encephalopathy in pregnant women with chronic liver disease are managed in the customary manner. The only therapy available for severe hepatic decompensation during pregnancy is liver transplantation. Orthotopic liver Chapter 40 Gastrointestinal and hepatic disorders in the pregnant patient 605 40 Transplantation has been performed successfully during pregnancy. 387,388 The MELD score can help predict clinical decompensation in a cirrhotic woman during pregnancy. For example, a MELD score of 10 or greater at the time of conception had an 83% sensitivity and an 83% specificity in predicting development of ascites, encephalopathy, or variceal hemorrhage prior to delivery in one study. 389 Wilson disease, see Chapter 76. Wilson disease in women of childbearing age is associated with amenorrhea and infertility. Treatment of affected individuals to remove excess copper may result in resumption of ovulatory cycles and a subsequent pregnancy. Pregnant patients must remain on medication to treat Wilson disease because discontinuation of therapy can cause sudden copper release, hemolysis, acute liver failure, and death. 390D penicillamine is potentially teratogenic in humans. 391 but has been used safely during pregnancy at doses necessary for copper chelation. 392 Similarly, trientine is teratogenic in animals but appears to be safe in humans as treatment for copper overload. Zinc salts such as zinc acetate do not appear to be teratogenic, and some experts favor use of zinc during pregnancy as therapy for Wilson disease for this reason. 393 Autoimmune liver diseases, see Chapters 90 and 91. Autoimmune diseases of most types, including autoimmune hepatitis, are more common in women than in men. Autoimmune liver disease has a variety of clinical phenotypes. In women, classic, type 1, autoimmune hepatitis typically presents around the expected time of menarche, but is associated with amenorrhea. When women with autoimmune hepatitis become pregnant, they have a greater than expected incidence of spontaneous abortion and preterm delivery. 394 Affected patients may also have disease flares during pregnancy and postpartum. 395,396 For this reason, treated individuals with autoimmune hepatitis who conceive a child should continue taking immunosuppressive medications during pregnancy. The doses of azathioprine prescribed as part of standard treatment regimens are not thought to be teratogenic. Autoimmune hepatitis patients should be carefully monitored during pregnancy and in the postpartum period. PBC is much more common in postmenopausal women than it is in their fertile counterparts. Women with PBC may experience an exacerbation of pruritus during pregnancy. 397 Pruritus can be ameliorated by treatment with ursodeoxycholic acid. 398 Although the safety of this therapy during pregnancy has not been formally proved. Hepatic tumors and mass lesions, see Chapter 96. Mass-like defects of the hepatic parenchyma may be discovered during pregnancy, usually as an incidental finding on U.S. Benign liver lesions found commonly in women of childbearing age include adenomas, focal nodular hyperplasia, and hemangiomas. Hepatic adenomas are associated with oral contraceptive use and may enlarge during pregnancy. Enlarging lesions can bleed and rupture into the abdominal cavity. Focal nodular hyperplasia and hemangiomas in pregnant patients have also been reported to hemorrhage. Women known to have a benign hepatic nodular defect should be evaluated with serial US to measure mass size and look for evidence of intralesional bleeding. Hepatocellular carcinoma occurs almost exclusively in persons with chronic liver disease and may present in the absence of cirrhosis in young people with chronic Hsv infection. At-risk patients should have standard screening for liver cancer during pregnancy. It must be borne in mind that maternal serum AFP levels are always modestly elevated during normal pregnancy. 399 and can increase further in cases of fetal Down syndrome, neural tube defects, and hydatidiform mole, thereby limiting the positive predictive value for diagnosing hepatocellular carcinoma during pregnancy. Hepatic fibrolamellar carcinoma has been reported to occur in pregnant women. 400 Fibrolamellar carcinoma is a slow-growing liver cancer usually found in young adults, median age, 25 years. 401 Unlike typical primary liver cancer, this neoplasm has no known association with cirrhosis or chronic liver disease and is not a cause of increased serum AFP levels. It is an aggressive neoplasm with a 5-year survival rate below 50%. Hepatic metastases from other cancers are rare in women of childbearing age. Hepatic vein thrombosis, Budd-Chiari syndrome, see Chapter 85. Pregnancy is a predisposing factor for the development of venous thrombosis. Hepatic vein thrombosis may occur in association with Hellp syndrome 402 and with preeclampsia in women who have an antiphospholipid antibody. 403 Pregnant women who develop hepatic vein thrombosis should be evaluated for the presence of antiphospholipid antibody and other circulating procoagulants, e.g., factor V Leiden, and also for JAK2, and possibly other gene mutations. 404 Pregnancy after liver transplantation. See Chapter 97, Women of childbearing age may become pregnant after successful orthotopic liver transplantation and deliver normal infants. 127,405,406 Delaying pregnancy until the second post-transplant year may be associated with a lower risk of prematurity. Transplant patients must continue immunosuppressive therapy during gestation but may need to have their treatment modified. Mycophenolate mofetil, a part of many post-transplant immunosuppressive regimens, is highly teratogenic. 407 and must be avoided in women of childbearing age who may become pregnant. Adverse effects of other immunosuppressive medications, including hypertension and hyperglycemia, may increase the incidence of fetal distress and preeclampsia in pregnant liver transplant recipients. In rare instances, pregnancy has been complicated by organ rejection.